Sir, I am
Hello.
calling on behalf of the Cardinal Society of
Hello.
India,
Hello.
Bihar chapter, for the upcoming Cardinal 20.
Hello. 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 Check. Hello. Hello.
Hello.
Hello.
I'm so sorry, sir, the phone got disconnected.
Sanghamita, are you there? Good evening.
Good
Hey,
evening.
good evening. Good evening, good evening. কেমন আছো?
হ্যাঁ, প্রোগ্রামটা জাস্ট লাইভ করব, ফেসবুকটা জাস্ট
হ্যাঁ।
কানেক্ট করছি।
ঠিক আছে, ঠিক আছে, ঠিক আছে।
ওকে, ওকে।
Sudhir Kumar.
Is anybody there?
আলো নেই।
ঠিক আছে ঠিক আছে।
Mondos?
হ্যাঁ হ্যাঁ
Hello?
হ্যাঁ দেখা যাচ্ছে দেখা যাচ্ছে।
দেখা যাচ্ছে বাট ওই ফেসটা ভীষণ ডার্ক আসছে।
গুড ইভিনিং স্যার।
Good evening. এই ঠিকই আছে নে ভালকে আহিছে?
আহিছে আহিছে।
হুম
স্যার গুড ইভিনিং আপনি আনমিউট কৰকচোন একবাৰ
পাইছো
স্যাৰ শুনি আছে এতিয়া
এতিয়া শুনি আছো
ডক্টৰ প্ৰীতম বৰঠাকুৰ স্যাৰ Yes.
Sir, good evening, Bhusani sir.
So thank you. Good evening. So বাকি সিহঁতৰ মানুহ আহিছে নেকি নাই কোনো
ইহঁতৰ মানুহ সব আছে
আছে না ওকে
27 জন মানুহ এন্টাৰ আছে এতিয়া স্যার এক্সাক্ট 7টাত স্টার্ট কৰিম স্যার
Sure. প্ৰীতম বাকি ভালে আছে ন
হয় আছে
আপোনাৰ ফেসবুক পোষ্ট বিলাক ইমান ভাল লিখে আপুনি বঢ়িয়া দেই
Thank you.
আপুনি সঁচাকে ভালকে লিখিব আৰম্ভ কৰক ৰিয়েলি মোক ইমান ধুনীয়াকৈ লিখে আপুনি ভেৰি গুড
এই কোভিডৰ পিছত গধূলি মানে অলপ সময় ওলাল যে এইবিলাকে কৰি থাকো
ভেৰি গুড এইটো আসলে আমি মেডিকেল প্ৰফেশনৰ মানুহবিলাকৰ এইটো একচুয়ালি থাকিব লাগে আমাৰ কাৰণে ইমান মেটেৰিয়েল আছে ন
হয়
মেটেৰিয়েল আমাৰ হাতত বহুত আমি ইউটিলাইজ নকৰো সাহিত্যিক বিলাকে ইউটিলাইজ কৰে কিন্তু আমাৰ হাতত কিন্তু তাতকৈ বহুত বেছি প্ৰেক্টিকেল এক্সপেৰিয়েন্স আহি থাকে ন
হয় স্যার
কিন্তু ভাবিব লাগে আমি নিজৰ ৰিয়েল কথাখিনি কলেই আমাৰ সাফিচিয়েন্ট না
এক্স্যাক্টলি
সেইকাৰণে
দিনত প্ৰগ্ৰাম কৰিলে কিবা স্যার
আজি অন্য কৰা নাই আমি এই টিভি প্ৰগ্ৰাম এটা কৰিলো নিউজ লাইফত
হয়
আধা ঘন্টাৰ কাৰণে সেইটো কৰিলো আৰু আৰু ৰাতিপুৱা আমি আছিলে আগতে 25 তাৰিখে ৱৰ্ল্ড হেপাটাইটিছ ডে বুলি পেলাই 25 তাৰিখে আমি এটা ৰেকৰ্ডিং কৰিছিলোঁ
অ
লৈ পেলাই সেইটো আজি ফেচবুক দিছোঁ আৰু
হয়
আজি আৰু সময় নহয়তো আজি বহুত বেছি ভিৰ থাকে পেচেণ্ট থাকে সেইকাৰণে সেইদিনাখনে কৰিলোঁ
উম
আচলতে আগতে
এতিয়া অলপমান পেচেণ্ট হৈছে আকৌ
পেচেণ্ট আহিছে বাঢ়িছে আচলতে ৱৰ্ল্ড হেপাটাইটিছ ডেটো মই বহুত বছৰৰ পৰা খুব ডাঙৰকে পাতি থাকোঁ
হয়
ৰান ফৰ দ্য লিভাৰ 2008ৰ পৰা মই কৰিয়ে আছোঁ তাৰমানে
উম
এই 2 বছৰ অলপ মানে শ্বৰ্ট কৰি পেলাই কৰি আছোঁ
উম সন্তোষ মানুহ কিমান এক্সপেক্ট কৰিছে
5+, 500+.
ওকে
আজি
500 আৰু হিউজ
আজি অলপ মানে এইটো খালি আমাৰ এইটোত আৰু আমাৰ একচুয়ালি ফেসবুক আৰু আপোনাৰ ইউটিউব দুটাতে এইটো লাইভ চলি আছে এতিয়া
অ
আমাৰ যিটো মিউজিক বেণ্ড আছে সেইটোতো ডিফাৰেণ্ট তোমাৰ নহয় তাতেতো মানুহকেইটা অলপ মানে সংগীত প্ৰেমী মানুহ চব আছে তাতে so they are not বেছি ইটোত নাছে সেইকাৰণে ইহঁতেও জইন কৰিব ভাল লাগিব আজি প্ৰগ্ৰামটো ভাল লাগিব আজি মানুহ বহুত হ'ব আজি মানে ইনসিডেন্টলি সাৰৰ টপিকটো যেনেকে স্যার ইনসিডেন্টলি হোৱাট টু ইউজ হৈছে আপোনালোকৰ দুজনৰ ড্ৰেছও ইনসিডেন্টলি সেম হৈছে
কালাৰ একে হৈছে আমি কথা পতা নাই এই বিষয়ে আগতে
মই এই অলপ আগতে আহি পালো আহি পাই মানে এই হস্পিটেলৰ পৰা অহা কাপোৰ কানি চেঞ্জ কৰি মোৰ আৰু শাৰ্ট পিন্ধিব মন নগলে আৰু মানে
ময়ো অলপ আগতে আহিছো
উম
পুৱাৰ পৰা হেক্টিক হৈ থাকে না
আজি বহুত বিজি গল
It's 7 o'clock.
স্যার স্টার্ট করুন নাকি
কিমান মানুহ আহিছে মানুহ
49 আৰু 5 মিনিট
ঠিক আছে
আৰু 5
যদি ষ্টাৰ্ট কৰিব পাৰি
আৰু 5 মিনিটস
5 minutes okay no problem
স্যার এইটো চাওক দেখা পাই আছে নে
মই আপোনাক দেখাই নাই নহয় নাই
মই ভিডিওটো কাটি ৰাখিছো
অ
this is Facebook live
Oh, Facebook আহি আছে না? Okay.
এইটো ফেচবুকত আহি আছে।
মানে
Okay.
who can see this?
ফেচবুকত হা
কোনে কোনে চাব পাৰে এইটো মানে
আপনি যেটো যেটো আছে
হা
সানাট্রা মিউজিক ব্যান্ড যেটোতে আপনি যে কবিতা কইছিলে স্যার
ওকে
the same things এটো চলি আছে ইউটিউবত ডাইরেক্ট লাইভ হয়ে আছে স্যার ইউটিউব তো আপনার চ্যানেল তো হুমাই
Oh, বঢ়িয়া। বঢ়িয়া।
সঙ্গীতা let's start sir 89
একদম সঠিক।
start কৰো মন্টুজ
sir start কৰি দিও already
Okay.
89 people joined
Okay. So, very good evening, everyone, and welcome for this today's webinar. First of all, I would like to thank the Guwahati Digestive and Liver Foundation for having me here as a moderator. Today is World Hepatitis Day, and on the occasion of World Hepatitis Day, as we resolve to make this world hepatitis-free world, we would like to discuss a very important, very pertinent clinical topic. The topic is what is to be done when a patient is incidentally found to be hepatitis B positive. As we all aware, hepatitis B leads to a wide range of wide spectrum of clinical presentation, starting from asymptomatic.
Could you try again?
Asymptomatic clinical, asymptomatic carrier. Patient may develop acute hepatitis, chronic hepatitis, then finally chronic liver disease, cirrhosis of liver, and even sometimes it may lead to hepatocellular carcinoma. Now, there are a lot of issues to be dealt with in this particular situation. How to know whether the patient is in a replicative phase or non-replicative phase, and when exactly to do certain biochemical investigations, virological markers like hepatitis B, E antigen, hepatitis B virus DNA, then how to follow up such a patient, how frequently to do the test, how frequently do the liver function tests, then how do you know the patient has developed chronicity, then when to start antiviral treatment, and so on and so forth. There's so many issues, and if antiviral issues and what particular antiviral drug to be given. Now, to deal with all these questions, we have with us Dr. B.D. Goswami sir, Professor Goswami is known to everyone, but for formality, I would like to introduce Sir to the audience. He is ex-professor and head of the Department of Gastroenterology Department of Guwahati Medical College. And he is one of the most prominent gastroenterologists of the entire country, in fact. And he keeps very keen interest in teaching. This is very important about Sir. He organizes national level conferences once or twice in every year in Guwahati. So we are fortunate to have him here in Guwahati. He exposes us to various national and international faculties in the field of gastroenterology. So with these few words, I'd like to invite Professor B.D. Goswami sir to start his deliberation.
Thank you, Dr. Borthakur, for your kind words. Yes, my friends, today we are going to discuss about a prominent and important practical issue which we used to see in our day-to-day practice, everyone, in any subjects, in fact, in medical science. So that is what the topic. It is incidentally detected hepatitis B. What to do? Yes, we used to get the patient, suddenly somebody, for so many reasons, due to investigation, they have got the positive hepatitis B surface antigen. And patient used to come to us or come to you. And next question is what to do, how to follow this patient, and what should be done. Let us discuss these whole points or the points what Dr. Borthakur has already mentioned about. So with this particular patient in the month of June 2010, he came to a doctor. What happened to him? He is a non-diabetic, non-hypertensive young gentleman. He went for the blood donation, and in the camp it was checked. Everybody nowadays, we know that B and C HIV are always checked before the blood donation, and they found that his hepatitis B surface antigen is positive. So obviously the patient was very much panicked what to do. He was very much afraid. The family members were also very much concerned. So there is no past history of jaundice in this patient. Family history of hepatitis B, C was negative. History of any surgery in the past of this patient is nothing. There is no dental procedure, surgery was also not there in this patient. He usually does not go to a commercial barber. The blood transfusion history is also negative on this patient, and he told that there is no sexual contact, to be precise. So that is what the patient has got the history. So obviously this is a case of incidentally detected asymptomatic hepatitis B. It does not have any symptoms. That's why he went to the blood donation camp and got detected hepatitis B. So this particular group of patients, what we call nowadays incidentally detected asymptomatic hepatitis B surface antigen positive patients. How it is usually picked up, how we can get them. Usually as a blood donor, just like this patient, the blood donation camp or any hospital before blood donation, they are detected. Or sometimes we have got the health checkup done, and this is also a mandatory in some cases. For example, annual health checkup in some of the corporates. Then due to the visa Some countries, it is a mandatory that you have to check it. Then the antenatal checkup in gynecology is a point to the for everyone. Also for chemotherapy for any carcinoma patient, before the chemotherapy, it is checked whether the patient has got B or C virus positive. Or if the patient is admitted to a hospital, nowadays most of the hospitals, they do the blood test to rule out B or C before the admission as like as HIV. So whom to check for hepatitis B virus infection? What we do usually, these are the group. Of course, there is a high risk group of patients. There is a acute viral hepatitis. Any patient with presenting acute viral hepatitis, always we used to check all the viruses, hepatitis A, B, C, D, E. Then chronic liver disease, once diagnosed, it is mandatory that we should check hepatitis B or C. Before blood transfusion, already I have mentioned. Before a job, some of the countries, they have got a rule that before a job, you have to check hepatitis B or C. Antenatal checkup, already I have mentioned. And the family members, we'll discuss later on why family members are checked. And finally, if suppose somebody has got hepatocellular carcinoma diagnosed, so immediately we should check hepatitis B or hepatitis C because these are the very common causes of hepatocellular carcinoma. So here is some facts probably I should present to you with hepatitis B. It is the leading cause of death today in the world. 2 billion people are infected. 325 million people are chronically infected. 1 million deaths per year. And it is 100 times more infectious than even AIDS. And also the carcinoma of the liver is 200 times more if the patient has got hepatitis B or C if it is positive. If you see from this particular slide, whole world we have got almost 6 billion people approximately. Out of that, almost 2 billion are infected already with B. And out of these 2 billion, almost 300 to 400 million people are chronically infected. And very interesting point is almost 25 to 30% of these chronically infected hepatitis B infection, they die of cirrhosis or the liver cancer. That is the fact of our life today. Then this is a spectrum of a B infection. In one way, we have got the incidentally detected asymptomatic hepatitis B surface antigen positive group. The other end, after some time, some years, the patient will ultimately end up with chronic liver disease or hepatocellular carcinoma. So out of that, almost 20 to 30% of these patients, they will develop the complications of hepatitis B, like cirrhosis or hepatocellular carcinoma. And most interestingly, majority of them are unaware of the problem. They have got B or C positivity. In fact, in today's world, almost 80% of the patient, 80%, those who have got the virus in their body, they don't know that they have got it. That is very dangerous because that's how actually the whole problem arises with the complications of the liver disease, chronic liver disease. How it is transmitted, hepatitis B, this is the scenario. The newborns from the long-term carriers, the intravenous drug users, prisoners, healthcare workers, individuals with multiple sex partners, and the blood transfusion or the transplant recipients. These are the way the patient have got the hepatitis B infection coming to their body. So what happens if the patient has got the infection? Usually, not always, there is the acute viral infection, what we call the acute hepatitis. This acute hepatitis, most of the cases, I will mention it later on, they recover certain percentage at certain age, but 1% case, they ultimately goes for fulminant hepatic failure, and it is a very serious condition. Mortality is very, very, very high. And the other group is the chronic hepatitis. B patient ultimately goes to stay in the blood, stay in the liver more than 6 months, and they ultimately end up with chronic liver disease. Again, this chronic liver disease, they have got the two-way. In one group, there will be inactive chronic infection. The hepatitis B surface antigen is positive more than 6 months. E antigen is either negative, maybe positive even, but liver enzymes are normal, and DNA level of these patients are very, very low. On the other end, we have got the active chronic infection, where the surface antigen is positive more than 6 months, elevated liver enzymes, and also the DNA is very, very high. And that is the problem of this group. Then this group again may be E antigen negative or E antigen positive. This E antigen positive and E antigen negative is important because for the physicians, it is important because of the line of treatment actually different in these two groups in different way. I will probably discuss in a later slide. Now point is the chronicity after acute liver hepatitis B surface antigen exposure. What is the chronicity? So what happens usually in case of adults, if the virus comes in the adults, almost less than 5% cases is after acute exposure, it can continue to chronicity. If the patient has got the virus in the childhood, neonates or less than 6 years, the 90% or 30% of these patients, they have got the chronic liver disease. That is the big problem, and that is the important for all of us to, if the patient has got the virus in the elderly or even the mature days, say 40, 50, after that, it is chronicity is less and less. But if it is in the childhood, the patient has got the virus, the chronicity is almost the rule of the day. This is what the picture again showing. In the neonates, almost 90% chronicity, but in the adults, it is very less than 5% of the chronicity we have got. This is the natural history of the hepatitis B virus. The phase what we have got, the immune tolerant phase, immediately after the virus coming to the liver. This is the sign, and this is what the DNA level is high. ALT and AST activity, it's a liver enzyme, is also usually in the lower side. Then we have the immune clearance stage after that, where the immune system of the body of the person, host, will work against the virus, and there will be a fight between the virus as well as the host immunity. And that's where we have seen the zigzag way of the DNA level and ALT, AST increasing, going down like this. Then inactive carrier state, after some time, it settles down. And the inactive carrier only that stays. And finally, it is the reactivation due to some immune issues or some due to comorbid condition, the reactivation of the virus may occur. And this is the time, whole phase, and the liver condition. You see the liver, initially immune tolerant phase, the minimal inflammation or the fibrosis, immune clearance phase, chronic active inflammatory changes here, then inactive carrier, mild hepatitis, minimal fibrosis, and the reactivation, this is the active inflammatory changes. Then again, another important point probably we should remember the clinical and epidemiological correlation. It is a clear picture today that endemic area, if it is low or if it is high, low is the European countries, North America, South America. The age of the infection is usually the early adulthood. Mode of transmission here, it is percutaneous or sexual. Chronicity, not very high. End-stage liver disease, also low. Hepatocellular carcinoma risk is low, but if it is the other way, the sub-Sahara, Far East, Asia. So here the endemicity is high for hepatitis B. The birth, toddler, they are infected usually. It is the perinatal or the horizontal transmission. Chronicity usually yes. End-stage liver disease high, and also the hepatocellular carcinoma chance is very, very high. So then it comes the evaluation. Whenever you get a patient with hepatitis B surface antigen positive, you have to evaluate the patient. So what is this evaluation? What we should do as a physician? The aim of the evaluation is usually to assess the stage of the liver damage, how much damage it has already done, to assess the activity of the disease process, what the stage at that particular moment, and also the assessment of the viral status. That's what we have to ultimately check one by one what we have. So if it is the incidentally detected asymptomatic hepatitis B surface antigen positive, these patients, the workup, that's what we should do. All of us, always we should remember these things to do it. You see the clinical features, any clinical features of jaundice, ascites, bleed is there or not. You check the liver function test. You do the ultrasonography of this patient to check the splenomegaly, to see the liver nodularity, portal vein diameter, and also ascites or not. Then you have to, if it is positive, it is better to see a CT scan to see the evidence of the cirrhosis. After that, to check for the hepatitis B E antigen. Again, I am telling you there is importance on the line of the treatment. E antigen positive, E antigen negative is a bit different one. Then again, another important point is your quantitative amount of the DNA level. You do an endoscopy, upper GI endoscopy, to see whether they have got the varices or not, because you don't know inside what they have got. If it is varices, there is a portal hypertension, it will be helpful to assess the patient. And in some cases, you assess nowadays easier one to do the fibroscan with the fibroscan machine. You can see the fibrosis score of the patient, and in a small select group of the population, you may go for the liver biopsy of the patient. Then there is the evidence of chronicity. So how we'll know that the patient has got already a chronic liver disease? Suddenly we have got to know that he has got the surface antigen positivity. If the patient has got ascites, splenomegaly, if the ultrasound is showing that there is nodularity or the echo sense is a higher one, if the liver function test shows the low albumin level, there is hypersplenism. It is obviously a chronicity. And again, of course, the fibroscan or liver biopsy will show you, and the esophageal varices on endoscopy, or your portal hypertensive gastropathy on endoscopy is showing again the portal hypertension. So this gentleman, what he did on 5th of June, when he got the virus positive, he is panicked. Family members are very much concerned. He consulted a family physician. So what happened after the consultation of the family physician? He is known to them, always he's a family person like. So he checked and he prescribed arsocol, it is the arsodeoxygolic acid. Vitamin B complex was given to him, and also entacavir was prescribed to the patient. Entacavir is a antiviral drug for hepatitis B. So family physician prescribed it, and the patient was after that he was a bit worried because he thought that I have to go with this medicine for long, long years together. It was explained to them, of course. So here is my question: is it justified to prescribe antivirals in any patient with the positive hepatitis B surface antigen of the patient? That is the question for everybody, for everyone. And the answer is, of course, not probably. Always we should check it, what I have already mentioned, and what I am also going to mention about why we should not start the treatment immediately. Always you have to go for the international bodies guidelines, where to treat the patient, when to treat the patient, whom to treat. And that's what the science is about. So after 2-3 days, again, this patient, he came to the gastroenterologist. He did not bought the medicine. He thought that, okay, let's have a second opinion. The second opinion, the question is, the gastroenterologist, when he saw the patient, he had a dilemma now. Why dilemma? Because of rest of the things are okay, fine, but about the entacavir, because a physician had already given him the entacavir, prescribed him. And now the question is, the gastroenterologist, for him it is difficult to stop the entacavir and to continue the entacavir, because if you continue, you have to whole life continue the patient with the medicine. If you stop suddenly, again it will be another issue locally. So this is the problem most of the time we have to face. That's why we should be very careful about. But fortunately, this patient did not bought the medicine till he got the consultation of the gastroenterologist. So that's why it was safe. We thought that, okay, you just wait, let us see whether you will need an antiviral or you will not need the antiviral. Let us see what we can do. If the patient has got hepatitis B surface antigen positive, what to do? This is the $1,000,000 question probably, because Dr. Bhattakur also mentioned about it. It is always we have to do, these are the things. You go for the detailed examination of the patient, detailed history, most of the history I have already mentioned at the beginning. You take the patient and the family members into confidence, advise to the family members. This is important one, because the transmission always goes inside the family member. Usually, if somebody is suffering from hepatitis B surface antigen positive, always we should check the other members whether they have positive or negative hepatitis B surface antigen. If it is negative, always you vaccinate all the family members, so that the blood or the blood products from this person does not go to the other members of the family. This is very important, and I will show you. And you have to vaccinate, and vaccination is not a big issue. Nowadays, it is very cheap vaccine price. So usually it can be given. Then the counseling is important one, because all the family members, they are very much concerned about. They are concerned about the food. They have got the fear whether this particular person will bring the virus to their family or not. they can take food together or not. All these issues are there. I remember once, long back, probably 15 years back, one of my patients, he came to the hospital because he had positive hepatitis B surface antigen, and whole family members, they did not allow him to stay at home. This is the reality. He had to admit it in the hospital only for the positivity of hepatitis B virus infection. I call the family members next day, explain to them. After 2-3 days after investigation, I convinced them that there is no harm. He can go back. He was a chronic inactive carrier. So that's why these points are very important. One, and after that, you can see this picture. This is the picture of a family from Arunachal Pradesh. The parents, they had the positive hepatitis B surface antigen, and the children, 2 children, all the family members, they got hepatitis B surface antigen positive. They came to me. Of course, it is almost 15 years back. Those days, Arunachal Pradesh, we did not have very good uh, uh, good centers for the awareness programs of hepatitis B, and also manpower was also lesser one. And these people were from the remote areas of the, so that's why always it is important, if somebody is having the virus in the family, check the virus with the other members of the family and vaccinate them. You see another family, the whole members of the family, they came to me. One boy, he came to me actually. This is what Masoom Ahmed from Silchar, in remote area of Kasar district. He came to me at the age of 32, and I found him a case of CLD with hepatocellular carcinoma in 2011. And after 6 months, he died. So then, when I got the patient, I inquired and I got the whole family history. The father, he is a carrier. Then we checked it. Earlier did not. His mother died. That time doctor told them that she is having the chronic liver disease, but it was not diagnosed as hepatitis B virus infection. And the rest of all members are suffering for hepatitis B at various stages. Somebody is carrier, somebody is chronic liver disease, like that. Even 2 cousin brothers also died. Later on, we inquired and we got that they died of chronic liver disease, most likely from the hepatitis B infection 1. So GE consultation now with us, it is the LFT, E antigen, it is very important one, always we check it, DNA quantitative test, genotype, and also important point is the hepatitis B core antigen, IgG and IgM. These points are very important for us to ultimately select the patient for the treatment or not for the treatment. So genotype, I am giving the another color to it because it is not so important one if it is economically not feasible one. We don't do it even. But if we can do it, it is important one. But otherwise also, it can be missed out, no problem. But LFT, mainly ALT, AST, E antigen, DNA, and the uh, core antigen, core antibody, IgG and IgM is important one. Now coming to the patient, what to do? Okay, if the patient has got surface antigen positive, always we should ask ourselves, is it acute case or it is a chronic case? Because we don't know, suddenly we got the virus positivity of the patient. And it is directly related with the treatment. Should we treat the patient or not to treat the patient? That's why acute or chronic is important. Why? Because this is the answer. If the patient has got acute viral hepatitis, usually there is the history of recent exposure, either sexual or others way, with jaundice, malaise, typical picture of acute viral hepatitis. And always in this group of patients, the ALT, AST will be more than 500, then it is obvious that the patient has got acute viral hepatitis. And chronic, what is the chronic viral hepatitis B? Is the chronic inflammation of the liver continuing without improvement for at least 6 months. And again, the chronic, we have got the classification with the no evidence of liver disease. Chronic viral hepatitis B with no evidence of liver disease, what I call earlier the carrier state only, inactive carrier state, or chronic liver disease with the liver disease, chronic hepatitis B with liver disease, where here the virus is there, surface antigen more than 6 months it is positive, but no signs of symptoms of liver disease. ALT, AST normal, fibroscan it is normal, and the normal histology if it is done by the biopsy. But here with liver disease means signs and symptoms of liver disease, raised ALT, fibrosis or cirrhosis on fibroscan, and also abnormal liver histology if it is done with the biopsy, and also you can get the sign symptoms with the ultrasonography. So these two group is important again, because next question will be who to treat and when to treat if the patient has got detected hepatitis B surface antigen positive. Here is the answer. If it is the acute viral hepatitis and no treatment is required, straight away, you wait for 6 months, you observe the patient, follow up the patient. After 6 months, if it is gone, hepatitis B surface antigen is coming negative, there is no issue. But till then, always you follow this patient. You follow up. That is important because they should not go away, because they can ultimately end up with chronic liver disease. But if it is a chronic hepatitis B, then you have to see whether with liver disease. If it is with liver disease, where ALT, AST is raised, albumin suppose low, other signs, sonography, fibroscan, everything is showing that the patient has got the abnormality already, chronic liver disease, and then the treatment is a must one. You have to treat the patient at any cost. Then again, the chronic hepatitis B, but without liver disease, ALT, AST is normal, then your clinically there is no issue, sonography is normal, fibroscan is normal, then you don't have to treat, but you have to follow them up. These are the group of the patient where we have to treat, and when we don't have to treat, but always we should follow these people, because the further they can go for chronicity. Then again, another point for our information, that acute or chronic, how will you know? This is what we have got. Sorry. The IgM antibody against the core antigen, if it is the positive one, it is the acute case. IgM antibody against core antigen, if it is positive, it is acute case. But if it is IgG positive, then it is a chronic case. That's how also you can correlate the patient. So again, here is the picture now. So June 14, he came to the gastroenterologist. What we did is, we checked the LFT that particular time. It is normal. E antigen is -1. Then IgM, it was the -1. IgG is +1. And also the DNA is below 20 international unit per ml. So these are the points we check, and this is the result what we have got. Please remember here, IgG is positive means he is already a chronic case, but his DNA is below 20, very, very low. His LFT is normal, mainly the ALT, AST, which is very important one. It is also within normal limit. So the question is what to do in this patient. Should we treat the patient or we should go for any more investigation of this patient? Or we have to follow up this patient. So obviously the parameters what I am showing here, it does not mean that we should go for the treatment. You will understand it later on when I will go for the other slides for the treatment guidelines. So we have to follow this patient if this is the picture. Then question is for how long follow-up? When you will call him back again? Usually, if possible, for the Western literature, it is usually 3 months. But for our country, it is very difficult to come every 3 months. So usually we follow the 6-month follow-up. Every 6 months, let the patient come for checkup. You check the points what I have already mentioned. If it is changing, you have to go for treatment or you have to again go for the follow-up. So usually 6-month follow-up is the ideal one. You repeat what I have already mentioned, but always these patients are chronic cases. So additionally, you check the alpha fetoprotein. Remember always that hepatitis B surface antigen, if it is positive one, these are the patients very frequently you can get hepatocellular carcinoma. That's why always alpha fetoprotein, every follow-up later on, probably it will be a better option for us. So in the month of December, the same patient after 6 months, he came back. So this time when we checked it, his surface antigen is positive, of course. ALT, AST, now all the liver function I'm not doing because I'm concerned with ALT and AST now because already we did it. So here it is 31, 36 within normal limit. DNA also again it is less than 20 international unit. So the question is, will you treat them? No, of course, because we have to follow them again. So then the patient came after 6 months again. We did the ALT, AST. It is normal, but this time his DNA is 984. It is high, but still the question is, should we treat this patient or we should follow them up? For me, yes, again, it is no, we are not going to treat the patient because again, we have to follow the international criteria. This follow-up, this time what the patient actually, he is tired of following up. He this time came back to us on the December 8th, 2015. After a few years, suddenly he appeared. This time when we did it, the only positive findings, important findings I am showing here, his ALT is 90, AST is 102, and DNA level is very high now. You can see 128,740. So DNA is high, ALT, AST both are high. ALT is more important one. If it definitely it is very, very high. So now the question is what to do now? Should we treat the patient or we will not treat the patient? So here, do you need any more investigation of this patient now? Probably yes. You should do an ultrasonography to see the portal hypertension, the hypersplenism, ascites, then the character of the liver. You check it. You do an endoscopy. Again, I mentioned earlier also, check for the esophageal varices now because his liver function is high. DNA is very high. And also, if it is possible, then you do the liver fibroscan machine. With that, you assess the fibroscore, what he has got. And liver biopsy, of course, theoretically, yes, it is needed, but at the moment, we have already mentioned that in select group of patients only, we go for the liver biopsy, otherwise it is not very much needed now. Alpha fetoprotein, yes, I have already mentioned, is a chronic liver disease. Then also the sonography should be seen, specifically if it is a longer period the patient has got hepatitis B surface antigen positive, any localized tumor, how is hepatocellular carcinoma is there or not, ascites and other points. We did it and it came out to be a normal one. We did the endoscopy. You see the endoscopic picture here. The esophagus is completely normal. There is no esophageal varices. We have the uh, acoustic radiation force impulse. So this RF machine also we can see the liver fibrosis score. Here, the diagnosis was early fibrosis of the liver of this patient now. And these are early changes. We got a chance to do a fibroscan. And this fibroscan also showing definitely he has got the 26.8 kilopascal of fibrosis. That means the early cirrhotic changes is already appearing to the patient. So next point is we have to start the treatment. And now, of course, we started entecavir 0.5 milligram daily dose. That's what we started with this patient in 2015. So here is the question, and this is the answer as well. When to treat a patient if he has got surface antigen is positive? When to treat? Always you check the ALT level, E antigen status, DNA level. If the surface antigen is positive, E antigen is positive, if the ALT is more than 2 times of the upper limit of the normal, and DNA is more than 220,000. You remember the E antigen is positive. This is what the criteria. More than 2 times of the upper limit of the normal and DNA more than 20,000, you have to treat the patient. If it is the ALT within normal limit and DNA also less than 20,000, you have to follow them up. In between, what to do? In between, you follow this patient. If the ALT is high, but not more than 2 times of the upper limit, you follow this patient, and if possible, you do the liver biopsy accordingly, you have to treat. If the E antigen is -1, so what is the criteria? Here is the criteria: ALT more than 2 times of the upper limit of the normal, DNA is more than 2,000, not 20,000. E positive, 20,000. E negative, 2,000 only. You have to treat the patient. And the other way, if ALT is normal, DNA less than 2,000, you have to follow them up. How to follow up every 6 months, what I have already discussed about. Then in between again, the same way, you follow them up and do liver biopsy if you consider. These are the 2 major groups, what we should do and how we should continue the follow-up or the treatment. But there is another group of patients we can see in hepatitis B positive patient. What happens here? For example, this person, he came to me with GI bleed, and this is the abdomen. Of course, the cirrhosis is a non-alcoholic. Surface antigen is positive one. We did the endoscopy, and this is the endoscopic picture. You see here, the patient has got the esophageal varices. So that means it is a case of chronic liver disease and it is already a cirrhotic one. It is decompensated already. And what we should do if the patient has got cirrhosis, compensated or decompensated, whatever it may be, this is the picture. If it is compensated also, the DNA level here, it is coming down to 2000. If the patient has got DNA level less than 2000, you observe or you treat, you wait. If the DNA level is more than 2000, you have to treat. Then if it is a decompensated one, whatever may be the DNA level, you forget about it, you treat the patient. So if the patient has got already cirrhosis, everything showing, the picture, you more or less have to treat the patient without depending upon your DNA level. Why we should treat this patient? Because of the picture showing here. From acute infection, chronic infection, ultimately there is cirrhosis, either hepatocellular carcinoma or liver failure and death. That is the end product of the hepatitis B surface antigen progression. This is what the pictorial picture showing the end. The annual risk of the hepatitis B progression. The chronic E antigen positive patients, E negative chronic hepatitis B is a 1 to 2%, 5% ultimately end up cirrhosis, decompensation 3%, from cirrhosis hepatocellular carcinoma 2%. So that's how it progresses. That's why we should treat. This is the picture of 5-year disease progression. Chronic hepatitis to cirrhosis up to 20%, cirrhosis to decompensation 20 to 30%, and cirrhosis to hepatocellular carcinoma 6 to 15%. And the fact is almost 25% of patients with hepatitis B patient, they die prematurely. That's what the picture what we have got. Then again, if you see the factors which are associated with the progression, age of the patient, alcohol intake, co-infection, if the genotype, if possible, C, pre-core mutants, so high DNA level. So all these points towards the changes, how frequently it goes to the progressive disease. This is a famous study from China, 2006. They showed clearly that if the DNA level is very high, the chance of the hepatocellular carcinoma is also very high. If you compare with the low DNA level, this is a very informative and very important landmark study, what we call in hepatitis B history. So if the patient has got again the normal ALT and AST, what I mentioned earlier, normal ALT and AST, usually we should not go for the treatment. But at the same time, I'm showing another slide where probably we should be a bit cautious one. This is the study they showed that those people who have got the normal ALT level, and we did the histology of this patient. Almost 50% of the cases, they have got the normal histology, but the rest, they have got some form of the fibrotic changes going on inside. So that's why even if the patient has got the normal histology, the other points we should remember, always we should follow this patient very carefully so that we don't miss the chronicity of the patient. Here, the ultrasonography, endoscopy, fibroscan, and liver biopsy. This is important point I'm mentioning for you. How to treat these patients? First of all, we should make the family members and the patient understand that there is no cure of hepatitis B infection till today. So that is the reality because they have to continue the medication. And of course, if necessary, they should take a second opinion, or if needs, we should refer the patient for a second opinion to a higher center. There is no harm because the patient can ultimately get the benefit out of it. Then another important point we should check for the hepatocellular carcinoma, the surveillance in the hepatitis B setting. This is because those patients ultimately, I have already mentioned, majority of them they have got the hepatocellular carcinoma later on. With the goal of the therapy of hepatitis B, this is what we go the goal to suppress the viral replication, induce disease remission, prevent cirrhosis and hepatocellular carcinoma. This is what the treatment option what we have got. Earlier we had the interferon, there is nucleoside in the tablet form, and also we have got the combinations of all. But this is the history of the therapy, the evolution. We have got the interferon, we have lamivudine, then adifovir, entecavir, peg interferon, talbibudin, tenofovir, and also we have got the tenofovir alphanamide. So all these medications are coming up to a new stage. And entecavir is of course a very good alternative, very good drug. But the question is, once you start, when to stop? This is also a big question, and there is no answer till today because we do not have a finite therapy. Lots of debates are going on about it, but actually, this is the treatment endpoint. We can end it when there is E antigen seroconversion, surface antigen clearance, normal ALT, decrease the pathology and fibrosis, CCD DNA clearance, and undetectable level of the DNA. But all these are almost like a miracle. It is not possible because we cannot we cannot clear the CCD DNA, and that is the problem we have got. So as of now, that's why in our day-to-day practice, we continue the medication. In conclusion, my friends, hepatitis B infection is a global health problem. The chronic hepatitis B is associated with the potential serious consequences with chronic liver disease, fibrosis, cirrhosis, and the liver cancer. There is no cure for chronic hepatitis B, but there are treatment options in front of us. The goals of the treatment are to suppress the hepatitis B virus infection and prevent further liver damage. The successful disease management will involve a partnership between the patients and the healthcare professionals, and also timely referral and the family counseling is important in the management of hepatitis B infection. Coming to our patient with incidentally detected asymptomatic hepatitis B surface antigen positive cases, the conclusion where what we have got, this is my message now. Most of these patients have a benign course. We follow them up, need careful evaluation with ALT, E antigen, DNA, and ultrasonography. The counseling is most important, which is based on the right understanding of the subject. And when in doubt, any doubt, you consult a specialist. With this, I thank all of you for your kind attention. Thank you.
Thank you, Professor Goswami, for this excellent and brilliant deliberation on hepatitis B. You have, in fact, summarized everything and made the subject so simple. And with your lucid presentation, you have made so many things very clear. Although you have simplified everything, I still want to ask you one question. In fact, I want to make it doubly sure. A patient when is found to be hepatitis B surface antigen positive, and he is completely asymptomatic, there is no history of jaundice and no history of any liver disease whatsoever. His liver function is absolutely normal and ultrasonography is normal, even CT scan is normal. Should we, in all patients, go for hepatitis B E antigen and the quantitative hepatitis B virus DNA?
Yeah, it's a very practical question. First of all, precisely if the patient has got B surface antigen is positive one, otherwise everything is fine, still you do the DNA level. Quantitative DNA level is important one because everything may be normal one, what I have shown in the last slide also, before finishing one, that even everything is fine, or on histology, 50% of these patients with normal ALT level, there may be some changes of the fibrosis. That's why DNA level is important. If DNA level is high, probably it will be easier one for follow-up, because next time after 6 months, when you will ask the patient to come back, then you can compare the previous and what is the level now. But the E antigen, probably we can skip it. If the patient can afford, you should do it. If it is not, you can skip it, because it will be needed one when we will need to go for the treatment. When you have to go for the treatment, that part, your E antigen positive, E antigen negative will ultimately decide the DNA level, 2000 level or 20,000 level. So that's why DNA, I think it is very important one, we should check it. E antigen, you can skip it. But follow this patient, that is important.
One more question, sir.
Yeah.
If a patient is persistently asymptomatic for say about 10 years, his liver function remains normal, his ultrasonography remains normal, can you in that stage, if because the patient is hepatitis B surface antigen positive persistently, but there is apparently there is no disease, can we in such patients ask patient not to come for follow-up for the purpose, or we still need to ask him to come for follow-up?
Yeah, this is another practical question. The point is, personally speaking, if you are asking me, I always ask them to follow them up, but not for 6 months. After 1 year, later on, I will make them come after 2 years, so that we can follow this patient. That is important one. But some people, there are some debate also is going on. For 10 years, everything is fine. DNA is also within normal limit or undetectable level. In those patients, even some people, they advise that yes, we can stop a patient for follow-up. But I personally, I ask them to follow up, but interval is definitely 1 year, after 2 years, like that.
Thank you, sir. Now I think we can take up some questions from the audience. 4 to 5 questions we can take up. We have some time.
Sir, there are some questions are coming in the YouTube and the Facebook. Should I read one or two?
Yeah.
Yes.
Some very, because these are not a doctor, but they are all viewers. The question is from Mr. Avinash. Doctor, how can hepatitis spread one human to other human, and how can we prevent? These are all layman people, all the general people. And what is the difference? Hepatitis and AIDS, please tell. By Mr. Satish Khurana.
Okay, one by one, let's see. The first question, how it is spread one human to another human. So B and C virus, both, but we are asking about the B and C. Most of the time, the two viruses, they spread through blood and the sexual contact from one person to another person. But hepatitis B, mostly it is spread the horizontal level, or suppose the person has got in the family, the mother is having the hepatitis B virus, the child will get the virus because of the touch all the time with the mother mostly, and that is what we call the horizontal or perinatal transmission. Besides, the virus can also come through the blood and even sexual contact as well. Hepatitis C also transmitted with the blood or with the sexual contact, but mostly it is through the blood. Nowadays, in this context, I should mention that here in Northeast now, everywhere the question is coming up about the drug addiction, for example. With the drug addiction, the same needle is used by these young boys or girls. The same needle is used in their group. So that's how very frequently we used to see nowadays more and more patients with hepatitis C virus infection, as well as hepatitis B virus infection, as well as the AIDS. The same needle is used. Or suppose the healthcare personnel, for us, for example, a doctor, we used to treat the patient with hepatitis B or hepatitis C. So chance of coming in contact with the blood products with these patients are very easier one for us. We can get the virus. That's the unfortunate thing. Then again, somebody is using the commercial barber. Nowadays, of course, it is reduced, but earlier the same blade or same razor was used. So that's how also it is spread. Then again, if you see the acupuncture or suppose the tattooing, all these are used by the needle. And if these needles are the same one using with the same needle, the different person, then also it can be spread. That's how actually it is spread. And next question is, what is the different hepatitis and AIDS? Please tell. I think Dr. Borthakur can please explain what is this different hepatitis and AIDS. I think he's not a medical person. That's what he's asking.
No, actually, the hepatitis B and AIDS both are caused by different agents. The viruses are different, but the mode of transmission is same. That is a point to be remembered, that the mode of transmission is similar. These through blood and blood products and by sexual contact. These are the two modes of transmission through which AIDS is transmitted. But important thing to remember here is hepatitis B is much more infectious than AIDS. Sir has mentioned it is about 200 times more infectious. And another important point Sir has just mentioned that is to be remembered is close personal contact. Through close personal contact, hepatitis can be transmitted. Generally, in case of AIDS, it is through personal close contact. It is generally not transmitted, but with hepatitis B, because very minute amount of body fluid is required for transmission. But so far as the disease-causing agent is concerned and the disease symptoms are concerned, it is altogether a different disease and it is altogether a different discussion when it comes to AIDS.
Yeah, another question is there, is pregnant woman can suffer from hepatitis B or C, then what could be position of the baby? It is also an interesting question. Yes, it is possible. The pregnant woman also can suffer from hepatitis B or hepatitis C. The point is, if the patient has got, or the pregnant woman has got hepatitis B infection, first of all, we try to stop the transmission of the infection to the child. Number two, we have to also protect the mother as well. So what happens if in case of hepatitis B positive, but mother has got the positive one, we check the DNA level. We follow them up strictly and we follow the DNA level. If the DNA level is very high, the science is showing with the very high DNA level, the transmission is also very high chance to the baby. So in those patients, we have to treat and we should give the antiviral agent, the medicine against the virus at the last trimester of the pregnancy. Last trimester of the pregnancy, we give the antiviral drug so that the chance of transmission to the baby is reduced. That's what we do the follow-up. After the patient, the baby is born, usually if it is not very much required, ALT level is normal, DNA level is normal, even during the pregnancy, we don't treat this patient, we'll wait till the baby can have his own feeding, not the breastfeeding state, because breastfeeding also ultimately goes to the baby with the breastfeeding. So that's why breastfeeding stage, till then we don't treat this patient with the antiviral medication. Only point is, if very high DNA level, we have to give the treatment in the last trimester of the pregnancy. That's what we follow. And that's why always the gynecologists also will agree. They always now check hepatitis B and C virus in the first visit itself, whether they are positive or not. And accordingly plan the pregnancy. In some cases, we ask them, or suppose the patient has got already chronic liver disease, we have to tell them the consequences and take the risk to have the pregnancy or to ultimately terminate the pregnancy. That's what, together with the gastroenterologist and the gynecologist, we share and decide. Then again, another question is, what would be the cost of medication for hepatitis B and hepatitis C in India? Hepatitis C, nowadays, we used to give a tablet form for 3 months, 90 days, usually, not always, but most of the time. And they cost you, the whole course is around 45 to 50,000 rupees total. For hepatitis B, around, there are different tablets in different companies, but it is also around 30, 40 rupees per day tablet it costs. But here, the hepatitis B treatment have to continue for long, long years. That's all.
Sir, I just want to ask you in this regard, out of these three oral drugs available against hepatitis B, adipavir and entecavir and tenofovir, do you have any personal preferences, and if so, why?
Yes, it is a very good question. First of all, the potency of the medication. First question. Entecavir is very potent medication, and so is the tenofovir. Even tenofovir alfafenate, but the newer version also has got the effective one, potentially very good drug. These two molecules. Adifovir we don't use nowadays because there is the question of the resistance. Earlier we used it, personally also we used it long years back, but subsequently got to know that after 5 years, the resistance is very, very high. So that's why nowadays adifovir is not used nowadays. Then we have telbibidine, another medication, very potent, but after 5 years, the resistance rate came out to be almost 25%. We don't use nowadays. Earlier, we used a lot. So that it is now we have got the entecavir and also we have got the tenofovir. Both these two potent, number one. Number two, the resistance is very, very less. Entecavir, for example, almost 1% after 5 years. So that's why these two are used. And I don't have any preference because both of them are equally effective one.
Thank you, sir. Is there any other question? We can take up one more question, if there is any. If there is none, then I think we can conclude the session. It has been a very nice, absorbing session, and I immensely thank Professor Goswami sir for his excellent presentation. And I now hand over the mic to Mr. Montus from Sanatra. This program has been conducted by Northeast Digestive and Liver Foundation in collaboration with Sanatra Pharma. So, few words and vote of thanks by Mr. Montus.
Thank you, thank you, Dr. Pritam Bhattakur sir. Thank you very much. And thank you very much, Dr. B.D. Goswami sir. It was really, really nice presentations. And sir, I can tell you that today, YouTube, we have crossed 782 people in YouTube.
very
And
nice.
this program was viewed Kolkata, Siliguri, all Northeast, 7 states put together. 479 viewers has been seen. They are still present. And Facebook Live was 78 people are viewing in Facebook, YouTube. It was great viewers have been said. Thank you very much, Dr. B.D. Goswami sir. It was really a crowded session, and we really enjoyed. Because what I see last 3-4 months, whatever the program we arranged, and this today's program was viewed more number of people. And thank you very much, sir. Everybody has enjoyed. Hope. Thank you once
And
again,
it was a
sir.
very practically oriented discussion. This is very useful, actually, very practically oriented. And
No, there are
sir
so
has
many questions
made the
has come, sir. I can tell you the questions are in YouTube. You will only get when you finish this program. You can go your channel, sir. Dr. Goswami, your channel has got almost 678 questionnaires. All general people, they have put 78 questionnaires. I cannot read all these questions one by one. And even in Facebook, some question I put it in the webinar. So thank you very much once again, sir. Thank you very much for having a nice presentation. Thank you.
Thank you, Dr. Bhattakur, for your kind words as well as the participation in the program. Thank you. We hope in future also we can meet and have some good discussion. Thank you. Thank you.
Thank you so much, sir. Thanks a lot.